Welcome. I'm Maureen O'Connor, President of Palo Alto University. It's a pleasure to welcome you to our webinar series, At the Forefront of Mental Health. Palo Alto University, or PAU as we're known for short, is dedicated to addressing pressing and emerging issues in the fields of psychology and counseling. Today's webinar is very timely. Mental health concerns are on the rise due to the pandemic and to the challenges it has created. At the same time, options for traditional mental health support, such as in-person therapy, are increasingly limited. Thanks to technology, there are digital options. Our goal today is to help you sift through them. I know you will enjoy hearing from our wonderful faculty who are experts in the field of digital mental health. They will be introduced in a moment. First, I'm very pleased to introduce today's moderator for this webinar, KQED's Community Health and Science reporter, Laura Klivans. Laura is an award-winning science reporter and the host of KQED's Deep Look. Her work can also be heard on NPR, Here and Now, and PRI. She teaches at UC Berkeley's Graduate School of Journalism. Before getting hooked on all things audio, she worked in education, leading groups of students abroad. One of her favorite jobs was teaching immigrants and refugees on the Thai-Burmese borders. She's done several fellowships, including the USC Center for Health Journalism's California Fellowship, UC Berkeley's Human Rights Fellowship. Laura has a master's in journalism from Berkeley and a master's in education from Harvard. We could not have a better moderator for this panel. We're delighted. Thank you so much for being here today, Laura. I'll turn it over to you.
Thank you, President O'Connor. Thank you all for attending today. So glad that everyone's expressed so much interest in this topic. Before we begin, I have a couple of housekeeping items that I want to share. So this webinar will be recorded and a link will be sent to you within a week. Please feel free to share it widely. We'll leave time at the end for questions. Please use the Q&A function at the bottom of your screen. So if you look down, you can see a little button that you can press and then you can type in there your questions. And please make a note if your question is specific to one of the panelists. Our panelists are experts in the field of digital therapy, and we will explore what that actually means in just a few moments. They're going to be representing 4 key areas of digital therapy: blended or coached digital therapy, self-help digital applications, email therapy, online face-to-face therapy. Joining me today are Dr. Barr Taylor, who will be focusing on blended or coached digital interventions. Dr. Taylor is a research professor at Palo Alto University and professor emeritus in psychiatry and behavioral sciences at the Stanford University School of Medicine. He's the director of the Center for M2 Health at Palo Alto University. He is a chief investigator on a long-term study examining the effects of coached interventions to prevent and treat common mental health problems in college students. Dr. Ricardo Muñoz, he will be discussing self-help digital applications. Dr. Muñoz is a distinguished professor of clinical psychology and director of the Institute for International Internet Interventions for Health at Palo Alto University. He's professor emeritus at the UC San Francisco and adjunct clinical professor at Stanford University. He specializes in the prevention and treatment of depression and the use of digital interventions to reduce health disparities worldwide. Dr. Donna Sheperis will be focusing on email therapy. Dr. Sheperis is a professor of counseling at Palo Alto University, where she also serves as associate chair for clinical training and interim director of the university's e-clinic. She has over 30 years of experience in clinical mental health counseling settings and is a licensed professional counselor in Arizona and Texas. She is also a board-certified telemental health provider. Dr. Kelly Coker will be focusing on online face-to-face therapy. Dr. Coker is a professor of counseling at Palo Alto University and the faculty director of assessment and learning outcomes. She is also a licensed professional counselor. So to start off, I'm going to start with Dr. Taylor, an overview of digital therapy. So Dr. Taylor, can you please talk about the different types of digital therapy that are available? And actually just really start with, what does digital therapy actually mean for those of us who are lay people?
Sure, thank you. Could I just emphasize how important what we're talking about is? There's been a lot of information coming about on the impact of COVID on people's lives. And the study that we just published in Lancet Psychiatry this week suggests that 20 or more % of people are affected with anxiety and depression. And in studies with people who have had already some mental illness, the rates continue to be even higher and sustained over time. In our college populations, where we have surveyed nearly 250,000 students and are providing digital interventions, we're finding rates of 30 to 40% of significant anxiety, depression, and insomnia. So think of the huge impact of COVID on our lives. And many of us have taken away a lot of the resources we normally cope with people, like face-to-face therapy. So what digital therapy has the potential to help people with is to provide services for mental health treatment and therapy at scale, at a very large basis. And Dr. Muñoz can go into this in more detail, but essentially the work that he has sort of characterized as a way to think about it, there's sort of 4 levels. So there's self-help, people simply using an app for whatever purposes, and I'm sure we'll get into and talk about this later. And that app can be directed by oneself, or it can be with a therapist who may actually recommend it or have some experience with it. And the next level is guided self-help, of which we have experts in this panel who do that, in which a coach or a moderator uses what is usually a standardized program online and internet to help people deal with their problems. And the third level is blended, in which individuals may do some teletherapy like Kelly does, some talk therapy like Donna does, some apps, even face-to-face, kind of a combination of digital approaches. And then, of course, there's face-to-face. And I think what we're seeing, well, we're in the middle of a revolution in psychology. Pretty much everyone is doing some aspect of digital therapy right now. So if you're even seeing someone with teletherapy, that is digital therapy. So those are the 4 categories. And it's very exciting to realize that at Palo Alto University and here we have really deep expertise in all of them. So maybe I'll just turn it back to you or Dr. Ricardo to explain this further.
Dr. Muñoz, would you like to share more about what digital therapy is and the different kinds?
Yes, I'd like to follow up on some of the points that Barr made, which is that COVID is having a tremendous impact, emotional impact on the population of the country. As Barr mentioned, 20% of the white population actually has severe emotional reactions to the COVID epidemic. The Black population, about 30% are reporting severe reactions, and Latinos, about 40%. So there are subgroups of the population that are even more heavily impacted. Blacks and Latino populations are having more cases of COVID and more deaths from COVID. So they are really being impacted more, primarily because a lot of the work they do, means that they can't do it online. So they're really suffering much, much more. Which means that some populations, for example, Latino populations where many speak Spanish, don't have access to therapists who are Spanish speaking, for example. Just as even without COVID, there are very few Spanish speaking therapists. Palo Alto University actually has established a Clínica Latina to teach therapists how to do therapy in Spanish and supervise them in Spanish. So we want to increase the number of therapists who do that. And one of the ways of trying to do that is to have online interventions that can reach people farther away, perhaps from where clinics are. For example, in California, psychologists who are Spanish speaking could help patients in the Central Valley, for example, where there are many farm workers, for example, who have very little access to psychological help. We are relatively lucky in the Bay Area that we have more therapists than in many other places in the country. But that's one of the reasons that digital therapy is important. Now, I was asked to speak primarily about self-help approaches, and one of the problems with mental health is that there aren't enough therapists to treat all the people who need therapy. I was just reading an article from the UK, from the United Kingdom, where they are systematically trying to train more psychologists to treat depression and anxiety particularly. And they are only able to treat about 16% of the people who have depression and anxiety, even with a very strong focus on training therapists. I don't have data for that in the US because we don't have a national health service in the US. But I know that most people who have depression, for example, do not get treatment. So how do we reach those people when we don't have enough therapists? And one way to do that is using online interventions, websites and apps. They have been found to be helpful in the treatment of depression. There are many studies now showing that online interventions, including in the UK, computerized CBT has been found to be very effective with mild and moderate cases of depression. And that means we can teach some of these mood management methods that are taught in, for example, cognitive behavioral therapy. We can teach them to people to try to prevent depression from becoming severe. When people start having depressive symptoms, and all of us have up and down moods, I mean, that's normal. But when our mood starts going down and crosses a threshold into a serious depression, what's called a major depression or a clinical depression, that's when therapy is very helpful. But when people start having lower and lower moods, we could intervene early. That would be a preventive intervention. We could prevent the onset of a clinical episode so that people, don't have to suffer serious depression. That's why self-help interventions would be useful, and they have been found to be very effective.
That's really helpful. I think we'll go more deeply into all of these topics as we go through this webinar. I want to just touch briefly on what we're talking about really when we talk about those other categories. So can we go to you, Dr. Coker? I know you were going to tell us briefly and just give us a summary of what this digital option is when you talk about online face-to-face therapy.
Sure. Thank you so much. And I really appreciate being here. I want to build on a bit of what Dr. Taylor and Dr. Muñoz is talking about from the standpoint of access. I think so much of the growth we see in all of these digital options have to do with providing increased access to potential clients and patients. I have been doing clinical work as a licensed clinical mental health counselor for many, many years and have been doing telemental health work, usually doing video face-to-face counseling for the past couple of years. And what I find in that work is so many of my clients are people who otherwise would have great difficulty in seeking services in a face-to-face setting. Mm-hmm. Stay-at-home moms, people who are homebound with illness, people in very rural communities with a lack of access to services. And what I appreciate about the video component of digital telehealth is that I am able, when I'm meeting with a client, I am still able to engage with them non-verbally. I'm still able to use my face and my expression to convey empathy, and really able to connect in a very personal way. Now, one of the things I think is really interesting, though, about these different ways to deliver digital therapy is that I've also had great success doing so with audio sessions, so even telephone. And as Dr. Sheperis will talk about in a bit, even using the written word to go back and forth with clients. That the trick for me has been, as I've shifted to this modality, is how do I really connect in a meaningful way with my clients, and how do I really work with them in a way so that we're starting from the place of a strong working alliance. One of the tenets of professional counseling is that we establish an effective working relationship with our clients. And I find that the video telemental health option of digital therapy really gives me an opportunity to do that. So yes, this feels like a really important response to COVID and what we're all dealing with. But we have also seen over the past 5 years pre-COVID, just a proliferation of this form of therapy. I mean, we know in the South and in the Midwest, for example, in 2017, nearly half of all mental health services were being delivered through telemental health.
Wow. I'd like to go to Dr. Taylor now and ask, can you give us some examples of what you are going to cover with us here? So the idea of blended or coached digital therapy, give us a quick overview of what that actually means and looks like.
Sure. So generally what happens is the therapist works with a client around a particular problem, and the client is connected to or using some sort of a digital interface or a platform. So the platform, the way that most of the blended programs are designed, follows some sort of a theoretical basis of therapy, like cognitive behavior therapy, where people look at their cognitions and their behaviors in ways that they can change them. So the coach acts as a guide looking at the individual's progress through that particular program. Most of the programs are fairly short term, 6 weeks to 12 weeks. They all should include some sort of data about how the person is using the program and working. And then there are many combinations of how the guidance can occur. So we at Palo Alto University are providing the intervention to the college students. So the college students basically sign up for the program. The coach does a number of things, monitoring to see how much they're using the program and help encourage them to use it. Then to help answer questions that deal with particular problems and really support their use of the program. Many of the programs in terms of the range of these include just conversations that aren't structured around the actual program, but other issues that people have. And in other models of blended therapy, like one we're looking at Palo Alto University for adolescents with depression, it begins with a face-to-face interview. So there's exactly what Kelly was talking about, an interview, you get to meet the therapist, and then you continue in that online. And in another model, people have a structured time where they get together on a Friday or something and have a teleconference like Donna's going to be talking about. And even to make it a little bit more complicated, but as this wonderful world is unfolding, on top of that, many of us who do blended therapy may recommend apps. Ricardo may get into this a little bit more, but there are wonderful apps available to people. I just want to mention a couple because I think they're so incredibly important. They're developed by the VA. They're free. Taxpayers have paid for them. There's one for that we were partly involved in developing, PTSD Coach. They now have an insomnia coach, and it's very exciting that a key person at Palo Alto University has been involved in developing COVID coach. So these kinds of tools could be used in, say, Kelly is doing teletherapy or telephone therapy, and she then recommends, she doesn't necessarily want, I'm sure she's great at dealing with insomnia, but she may not want to as a focus. So she would say, well, maybe you would consider using this VA PTSD sleeping app to help you as part of the process. So as we go forward in the field, it's a mixture of these combinations. To reflect on what Ricardo said, there's huge amount of evidence that these kinds of blended therapies worked as well as face-to-face therapy. So in England, for instance, in the part of the program that Ricardo was talking about, that we also are involved with slightly at Palo Alto University, there are a whole range of programs that are developed and delivered by a coach in partnership with an individual who's using them. At some point, I'd like to talk a little bit about what the client or consumer needs to think about in terms of actually using all of these programs, but it might be better to defer that question until a little bit later. The other thing is, I think many of us see is that we're in the middle of a revolution in mental health delivery. I mean, what Kelly said is incredible. 5 years ago, hardly anybody did teletherapy. Now all of the therapists are doing it. And as we go forward, it'll be really interesting to see how people decide what the nature of their clinical practice is going to be. And I do some clinical practice. I've done it forever. And like all of us moved on to teletherapy. And to me, it's been great. But one of the big advantages is that people that I see, there's a huge savings of time and convenience. They don't have to drive to my office, find a place to park, worry about getting a parking ticket, and then worry about getting home in the middle of a traffic jam to some place. So there are many levels. I think all of us at Palo Alto University are deeply committed to sort of, the issues of social justice and services to underserved populations. But for lots of people, there are great benefits in just providing therapy that is more convenient, affordable, and huge evidence suggesting that it's effective. So thank you.
That's so interesting. And I'm very excited to follow up on that further as we keep talking. I want to go to Dr. Sheperis now, and I want to ask you about the type of work that you are doing, and to specifically describe what an online or email practice even is.
It's a great thing to start with, right? So clinicians had an option years ago to begin starting to work in encrypted chat platforms, maybe even having some phone sessions. But historically, when we think about the concept of therapy, it is a therapist and a client in a room, in an office with some nice comfy chairs and a window, probably. We don't think about therapy outside of that very historical model. We've really made a shift in the last decade. So for the last 4 years, my practice has been exclusively online using a combination of audio video sessions and messaging sessions. So I think, Laura, the word that you used was email, which is not exactly accurate. One of the things that I think clients need to know about coming into this type of work is that a clinician is not going to email your Yahoo account or your Gmail. These are platforms that are established specifically for therapeutic work that are encrypted at the same level of security and safety as your banking platforms are, for example. And all of the work that you do in written form with a therapist stays housed within a platform. So effectively, from a client perspective, you see all of the work that you've done with your therapist anytime you want to open the platform and look at the work you've done. Now, again, as I mentioned, a decade or so ago, we were using some encrypted chat, we were using some encrypted emails. Those things did exist, but what we really see now is this platform that houses the type of work that we do. And for both Dr. Coker and I, that has been this combination of whatever the client needed. Does the client need more video face-to-face, a more traditional approach to therapy? Does the client need more frequent, briefer intervention using messaging, which my clients will often refer to as text, but again, it occurs in a platform. So what I tell clients is it's going to be a little bit like having a therapist in your pocket, in that you are not doing as Dr. Taylor was describing, you don't have to take that 2 hours off of work, half hour to drive across town, 50 minutes for a session, another half hour back to work. You can literally pull out your smartphone these days and either have a video session or a text session. In the messaging side of things, I also tell clients, or they've actually told me, that the experience is a bit like having, this is going to be my Harry Potter reference for Harry Potter fans. It's a bit like having an interactive journal that talks back to you, but not in a creepy Tom Riddle way where it's mean to you. But when you write as a client, at some time later that day or the next day, your therapist is going to respond to you. So you're maintaining some active communication, which we're finding some clients really like, these small bites of therapy throughout their week, as opposed to, gosh, I really need I need to remember to talk to Donna about this 2 weeks from Thursday when I have my next appointment at her office. So it's a big difference from the client perspective. And then from the clinical perspective, I don't have the same level of overhead. I have some security and privacy opportunities for my clients that I wouldn't have if they had to walk into an office front. So there are a lot of advantages that we see for both the client and the clinician in the process.
You all have laid out a bunch of really interesting options. So I'd like to go back to the question that Dr. Taylor posed, which is, what does somebody look for? How does somebody choose from all of these options when they want to access digital therapy?
I think that is a choice that's co-created with the therapist. Now, of course, a client may decide to use an app, a self-help app on their own, and that's not a co-created choice. So what we do, particularly at PAU, is we try to make people aware of these self-help opportunities that they could use prior to needing more of an intervention. But when a client comes into a therapeutic environment, the therapist and the client are going to work together to figure out what's the best choice for you and what is going to help meet those treatment goals, because it's going to be different for everyone. Outside of that, the client is also looking for a therapist they can connect with, because if you cannot connect with the therapist, you are not going to be successful no matter how well trained the therapist is or what type of presenting problem you have. We have historical research to support that. And then you also want to make sure that the therapist has some experience. Dr. Coker and I are both board certified telemental health providers. So we have experience and a certification to support what we do. We'll see more of that now that more of the therapeutic population has moved to an online practice. We'll see better training, better certifications, and it will be a more visible element when you make a choice among providers.
I'd love to piggyback on that just a little bit too, Laura, just in terms of that choice of type of service, because I think another thing that's important to remember is that digital therapy and these different options are not always the best option for some clients. So I think some of the things that I've certainly encountered when I have done an intake process with a prospective client in a telemental health environment is also to ascertain if this is a medium that's going to work for them. Some of those considerations might be as simple as straightforward as access to adequate technology. Access to broadband internet is going to be an important consideration if this is even going to work for a particular client. I think we're learning more and more, and Barr talked a little bit about some of the research on outcomes. We really are learning that we can address about any issue or concern that we would address in a face-to-face setting, in an online setting. But there are some other considerations, things like risk and safety of your clients. It's a little different to do a risk assessment with a client in a telemental health setting versus in that comfy chair sitting across from me in my office, especially if there is a concern that would require some kind of an immediate intervention. So there certainly are some other things we have to be mindful of when we're considering expanding into a telemental health practice and the types of clients that we might work with and that might be appropriate for that setting.
Dr. Coker, can you spell that out a little bit more, what you mean by that, about the risk specifically?
Sure. So every clinician, every therapist who works with a client, one of the things you do early in the clinical you do a pretty in-depth intake assessment. And this just gives you information of the nature of the concern that the client is bringing. So one of the things we always assess for in level of risk is there a potential for suicidal ideation? Is there a potential for a risk or harm to somebody else in the client's life, or is the client themselves potentially being harmed? So those are some of the examples of risk that we might encounter in a therapeutic relationship. So when we're assessing for that level of risk, the thing that I'm always doing on the other side of that, and the thing I do with every intake with a new client, is I want to be sure that I have information that I might need to intervene if there is a risk. So for example, in the platforms where Donna and I work, clients are required to provide emergency contact information of somebody who is immediately accessible to them. So if I needed to reach them, I could. Another thing I always do is if I'm working with a client, say in another part of the state that's not in my 911 jurisdiction, I want to be sure I know what is the emergency services number for that place. So these are just some of the extra things that you have to put in place when you consider just initial intake information, but also the potential for risk assessment when you're working at a distance.
Great, thanks. Dr. Muñoz or Dr. Taylor, do you have anything else to add about that if somebody is looking for help with one of these tools, advice?
I could start, Ricardo. First of all, we're in the middle of this revolution. There are all kinds of, I think more in the space of things like Talkspace and blended therapies, all kinds of options available to consumers. And there are many companies that have gone into this space, which I think is actually a really good thing. But the consumer has to be sort of eyes wide open because most of them have not really been evaluated. There's not really a lot of evidence about how they work with people. And I think that what Kelly was saying about look at, and Donna, the relationship and is this going to work for you is important. It's hard to know exactly what the level of training is behind some of the people who are delivering these particular programs. I think is a greater good served because these are available to people. So doing a little bit of background about the program, I think is a good thing. For apps, there is a website people can go through to check out an app that we recommend called CyberGuide, CYBERGUIDE. And if you're interested in using an app, you can actually look at that and see some of the consumer reviews of it, privacy issues, and other things. I think that what is partly missing in the field, but really important, is what the client really wants to get out of the experience and how they're going to be preparing themselves for the experience. And for all of us who live in this world of doing digital therapy, there are a number of issues for people to consider. Let me just name a couple of them. First of all, you have to consider where you're doing the therapy and how it's going to be. Is it going to be at home? Is it going to be private? Is your family going to come in? Are you going to be sitting in a traffic jam? All of these are kind of the pre-preparation consideration. And I generally favor face-to-face therapy, but I just don't think it's realistic that people are going to be able to do it. So you have to, as a client, bring to the experience a sense of, I'm going to find a way to get the most out of this. So a practical issue is, how do you organize your mental health app on your phone, for instance, and how are you going to use it? And how do you want to be notified? These kinds of pre-thinking about it are really critically important. And evidence is that most people, because apps there are 8,000 or 9,000 mental health apps, I think. Most people use them like only once. So it's partly not something like a meal where you're tasting things, but you should think about making some sort of a commitment and sticking with it long enough to see whether it's going to work for you and whether you're going to get something out of it. So I really think that when going in, whatever choice you're going to make, even the ones I've mentioned already about the VA COVID app, people should think, okay, I'm going to go through this program. I'm going to give it my best. And if it tells me to do something, I'm going to go and do it. You know, if Dr. Sheperis wants me to do something, I'm going to consider going along with that. So the sort of thinking in advanced preparation, and also realizing that change doesn't occur instantaneously. People often go to the digital space looking for very rapid change. And rather than thinking that this is a problem that I have had for a while and I need to work through it at a level and give it enough time to have a positive experience. So The front end is really critically important in what the client brings to the experience.
Let me follow up on that. There are three places that I recommend for people who are interested in self-help interventions to look for. One of them is Cyber Guide, which is spelled P-S-Y-B-E-R Guide, Cyber Guide. As Dr. Taylor said, they actually review and evaluate the apps or websites that are focused on depression, anxiety, and a number of other things. So that's a really good source. The other one, which contains COVID Coach, which Dr. Taylor also mentioned, is the site is My VA Apps. So MYVAAPPS, My VA Apps, because these apps were developed by the Veterans Administration. So, Dr. Joe Russick, who's part of the e-clinic and faculty at PAU, was led that group for many years. And then the third is Palo Alto's own Silicon Valley Digital Apothecary. So if you Google that, Silicon Valley Digital Apothecary, you'll get to our page. And we have, we're just starting this, and we have two interventions now. One focused on mood management, developed by Dr. Jan Laken, who's one of our faculty. And the other one is a website that is focused on preventing postpartum depression. It's called the Mothers and Babies course, and Dr. Aline Barrera, who is one of our faculty at PAU, has developed that. We also have a couple of webinars, one in Spanish and one in English, that I presented, focusing on preventing depression during COVID. And all of these are available at no charge. So one of the issues when you're thinking as to what kind of intervention to take is to think of it in a way that's described as stepped care. Stepped care means that you begin with a relatively low-cost intervention first. If you have mild symptoms, for example, you try to prevent the depression from getting worse, right? But as your symptoms get worse and worse, you need to have something more intense, eventually needing therapy. And there are times, when you actually will need to actually see somebody in person, face to face, I mean. So none of these works for everybody. That's really important to know. There are studies showing that the first treatment that you take, for example, for depression, is likely to be effective for something like 50% to 60% of the people, the first treatment, right? If the first treatment doesn't work, don't give up. This is, again, something that Dr. Taylor was saying, don't give up. You need to look for another treatment, all right? Sometimes one therapy won't work for you, another therapy will, or maybe antidepressant treatment. There are many treatments for depression, and the problem is giving up. The same thing is true for apps and websites. If you use one and it doesn't work for you, don't assume that any psychological intervention isn't going to work for you, right? It just means that one didn't, but you can try another one again. So that's something to be considered. And finally, Dr. Taylor mentioned the fact that people are more likely to be able to come, to online therapy. I worked at San Francisco General Hospital for 35 years before coming to PAU. And I still have contact with people there, and we're finding a couple of things. First of all, our patients who are very low-income patients who have very high no-show rates, their no-show rates are getting better. That is, they're less likely to no-show when you do things online, precisely because of the reasons that Dr. Taylor mentioned. They don't have to take a bus across the city to come and so on. So they're more likely to show. And even homeless patients. San Francisco General has given them smartphones so that they can be in touch with our homeless patients because, of course, it's very hard to find them, especially now with COVID. So there are many, many advantages to using digital interventions, which we're really finding out now because of COVID, because so many people didn't want to use them before, and now they have to use them, and they're finding they actually work. So, yeah.
That's incredible. That's wonderful to hear about what's going on in general right now too. So they work, you're saying. Can you all talk about, whoever wants to take this one, the evidence about how these tools work as compared to what we think of as traditional therapy, going into someone's office and being face-to-face with a therapist?
Well, let me offer one piece. One thing that we're seeing in some of the platform use is that clients, and this is pre-COVID, so that clients who choose a app-based therapeutic platform, about 50% of them are leaving services because they've actually completed treatment goals. That's a much higher rate than we see in community mental health centers, where people tend to leave services because they can no longer afford it, or they just run out of steam, or maybe they hit a wall and don't want to keep working. But to actually complete a treatment plan and end on that kind of a note is the therapist's dream, and we don't see enough of that in some of our regular outpatient work. So that's one piece, and I know there are others that y'all can speak to as well.
Well, I think some of the, I'm sorry, Ricardo. I was just going to say, I think some of the exciting research that we're seeing is we're also starting to see research that looks at specific outcomes with specific populations using telemental health. So there was a very recent study by Stewart and colleagues that looked at treating children with PTSD using trauma-informed cognitive behavior therapy, which we know is a proven and empirically based therapy for that population. But the study specifically looked at delivering the therapy in a telemental health setting, and that the reduction of symptoms were comparable to doing the same kind of treatment in a face-to-face setting. So I think whereas, earlier when we first started on this explosion of telemental health, we really were seeing more of the studies of, is it good enough? Is it as good as what you would do face-to-face? But now we're really starting to dig into some of the particulars of types of treatment, types of clients, and types of outcomes. And again, we're seeing comparable evidence of efficacy for whether it's online, digital, or whether it's face-to-face.
I wanted to follow up on something that Dr. Sheperis mentioned, which is cost. And I wanted to just let people who are here at the webinar know that the training clinic at Palo Alto University provides sliding scale therapy. And our doctoral students who are training, there, are very closely supervised by faculty. The training clinic includes several clinics, including the e-clinic. And Dr. Sheperis is now the interim director of the e-clinic, and Dr. Taylor was one of the founders of the e-clinic. And of course, they provide online therapy on a sliding scale. But we also have other clinics. We have our regular clinic that provides regular services in English and so on. We have Clínica Latina that provides services in Spanish. We have another clinic that focuses on LGBTQ patients. So people who are taking part in this should let people know that this is available here at Palo Alto University.
Maybe I could talk a little bit about a study we just did, Laura, on efficacy. We were looking at eating disorders in college women. So in some of the work where we work with the National Eating Disorder Association, we screened about 700,000 people. And we find that a very large number of those want therapy, and very few of them have access to therapy. So of that large number of people, just a very small minority. So one of the things we wanted to do is see whether a guided, coached program would work. So we took 700 women from various colleges around the country and randomized them into the treatment group or not, and then followed them for 2 years. And there was a significant reduction in eating disorder pathology with the guided program over time, which was enormously gratifying. because again, as we've all talked about, this is a model that can then be disseminated in various ways. In meta-analysis, in which we gather together a whole bunch of studies and compare them, I think that there have been something like, what is it, Ricardo, 13,000 studies of cognitive behavior therapy. And the meta-analysis involved hundreds of studies for anxiety and depression in particular. The evidence is overwhelming of the benefit of digital therapies, and substantial evidence that digital therapies are equal to face-to-face therapy. I think there's also an encouraging bit of evidence that some personalization also really improves outcomes. So at least in the blended therapy model, working with a therapist part-time online or having support from a therapist seems to confer a little bit of benefit. And just not totally related to that, but just to underscore, I think what Ricardo said earlier is so critical that people I think in the future of digital therapy of kind of, if it doesn't work, look at other options, but hang in there and really give these things a try. Particularly if you're going to go to the apps, you really need to put your heart into it to see if you can get the most out of it. Because the average number of apps used, a number of sessions for the average app is 1, and then people move on to other things, which doesn't say so much that the app isn't effective. It says that the people using it may not have brought to it the expectation they're going to get the most out of that experience.
The modal number of sessions in face-to-face therapy is also 1. Modal means
Right.
frequent on, right? People come in and they don't come back. I mean, that's
Right.
But in terms of efficacy, focused on depression specifically, there are meta-analyses, which are studies in which they take all of the randomized controlled trials, all the scientific trials that have been done, and look across all the ones that are available to see what the effects are. And these studies in the area of depression show, first of all, that completely fully automated interventions are effective to manage depressive mood. Guided interventions, the kind that Dr. Taylor does, are more effective. So when you have a coach, when you have a guide to help you, so you don't drop out, which that's the biggest problem, dropping out and not using the intervention. The likelihood of dropout is less, and the likelihood of effectiveness is higher, right? So when you have human contact, effectiveness is better. And of course, having direct therapy online or actually in person, of course, is the most intense, most effective. However, there are some advantages to the self-help interventions, one of which is the marginal cost of interventions goes down tremendously the more that people use it. I've done several studies, worldwide randomized controlled trials for smoking cessation with sample sizes of 18,000 people, for example, which are very hard to do face-to-face. What we were looking at is whether the website for the smoking cessation website, which we did in Spanish and English, by the way, would match the patch, the nicotine patch. And the nicotine patch is one of the most used ways of trying to help people quit smoking, and it yields about 14 to 22% quit rates at 6 months. And so our website yielded rates at the same level, about 26% at 6 months and 20 and 21% at 12 months. But the cost, in our last study, we had 18,000 plus people participate and about 3,500 quit smoking. And if we had used nicotine patches, it would have cost $3.5 million to give people enough patches, so that many could have quit. We did it with $200,000 over 2.5 years. The difference in cost is amazing. So you can reach many more people. The problem is many people drop out and the effectiveness is not as high. But you can help a lot more people with these completely automated ones because you can give them away to the whole world. And that's something we need to pursue. And again, the ones who don't do well need to go on to more intensive interventions, of course. But we should begin with the simplest ones that can reach the most people and help the most people throughout the world.
That's very interesting. Thanks for bringing up the financial aspect of this. From the perspective of both the client and the provider, what are the differences in cost here? For the client, how much are they needing to pay out of pocket? Is insurance generally covering these types of digital therapy? And then for the provider, are you able to submit to insurance? And how is the process different on your end? Whoever would like to take this first.
I'll start with it.
Great.
It's a little bit of it depends response to the question. I have worked across 4 different telemental health platforms that sort of run the continuum of operating very much just like an independent private practice, where I pay for the platforms that I use, that I have business associate agreements with those platforms to ensure HIPAA compliance and privacy. And when I worked in that way, it was like running a private practice. And so clients found me through, say, psychologytoday.com. And I offered those services through a sliding fee scale model. I did not bill for insurance. I based my fee on what clients could pay based on their income. And I had out-of-pocket costs just to cover the use of those platforms. The other end of the continuum as a provider is working for a platform like BetterHelp or Talkspace or Teladoc. Those are 3 that I've worked with, where I, as the provider, don't pay the platform for use, and I get the HIPAA secure platform. Everything is secured, as Donna said, including client records and communication. And clients may then pay the platform in a few different ways. Some of them are subscription based, which is sort of a new model for mental health services. They might pay an actual subscription fee for a type of service they're getting, whether they do primarily video sessions or whether they do chat sessions or all text sessions. Some of the platforms like Talkspace and Teladoc do accept insurance. And so we are considered providers who also are under those insurance panels. And then clients can use their insurance for those services. A lot of them fall under employee assistance plans. So EAPs will provide a certain number of services. And I apologize that I'm in the dark and it's loud, but there's a huge thunderstorm here right now. So if I lose power, that's why. So I'll turn it over to someone else.
Where are you right now, Dr. Coker?
I'm in North Carolina, so I'm just south of Raleigh, and I think we're getting the remnants of whatever the last tropical storm was that came up through the Gulf. So.
All right. Yeah, very different experience than here in California.
Absolutely.
I think the cost situation does run the gamut for both practitioners and for clients. If you're seeing a therapist in the Bay Area, you may very well be paying $250 per session out of pocket because you may choose not to apply your insurance. There's still a lot of insurance stigma around mental health services. Some people just prefer to pay out of pocket, not have any records going to insurance, et cetera. When that provider moves because of COVID to a telemental health situation, that provider is not likely to charge any differently. When providers intentionally select telemental health as part of the work that they're doing, they may do that at a cost advantage to the clients that they serve. A therapist in California is now available to all of California residents and could see people in areas where they might not already have a footprint. When you're looking at, from a client perspective, using insurance or a subscription-based service, which many of the platforms that we're talking about are, a lot of the subscriptions run around $100 a month for messaging services, which equates, depending on your copay, to somewhere around 4 sessions a month, which is about what you would get if you fully utilize the platform, as Ricardo and Barr have been saying. If you buy a subscription, just like a gym membership, and don't use it, it stays dormant and doesn't benefit you. And that's the really unfortunate side in the subscription side of things, is that we really like to see people use those because you can get more bang for your buck. Then if you add in some of these free app pieces, you're really getting a lot for your therapeutic dollar. To Kelly's point, though, especially since COVID, we have seen insurance companies loosening their restrictions around telemental health services. We have seen licensure boards loosening their restrictions around the provisions of services. And I would do a disservice to my PAU community if I didn't go back to Ricardo's point that at PAU and most other university systems that train therapists, there are likely graduate students in training who provide these services at a very reduced cost to the community. So no matter where you are on the financial spectrum, there should be some way for you to access these services.
Another aspect of this, in the part of the work that I do involves developing programs that can be integrated into HMOs and so forth. So what's happened in places like Kaiser has a contract with the group that we work with, SilverCloud, to provide digital coach services for nothing, basically. So one thing that individuals who belong to, and it's becoming much more widespread in terms of the healthcare providers, because it actually is a very affordable thing for them and they get a big payoff. Ricardo didn't mention that, but from the healthcare system, if you just reduce depression rates, it has a huge economic benefit for the healthcare system as well as enormous personal benefit for those who are less depressed. So we're beginning to see the access to these programs being paid for entirely by HMOs. And I think in the future, a lot of companies with insurance will give this as an option because it really works for everybody. You know, it's less expensive for them to provide. They're effective, they're accessible, they're affordable, and they're, getting to be very available. So it's great.
I'd like to add to that a little bit about prevention. There are now studies that show that you can prevent about half of the new cases of depression, particularly for postpartum depression. Right? We developed the Mothers and Babies course at San Francisco General, and it's now being used across the country as far away as Greece and Kenya and Tanzania. So the problem is there's no reimbursement for prevention treatment, so prevention services. So you have to wait until you're depressed to be able to have your insurance pay for treatment, which is really a shame, because you could obviously help, let's say for postpartum depression, you could help the women who are pregnant, not to suffer depression during this period, but also their babies, because their babies also, suffer when the mother is depressed, because the mother is not able to have as much energy as she does when she's not depressed. So one of the things that I've been suggesting is that we should develop routine. Actually, it's been suggested by the U.S. Preventive Services Task Force in a article in JAMA, February last year, 2019. They are recommending that women at risk, pregnant women at risk for depression, be routinely offered preventive services. Imagine if we did that in California, that every baby born in California in 2021, let's say every baby born in California, has had their mother be screened for risk for depression. If they are at risk for depression, they receive a preventive intervention, and about half of them would not develop the depression. The ones who do develop it would receive treatment. They would receive treatment for the depression, and we can probably help with the first treatment, cognitive behavioral therapy, for example, about 50 to 60% with just the first treatment. And those who don't do well with that, they would get additional, other treatments, so that
it's 12 o'clock.
So the cohort of babies born in California in 2021 would have much less of the sequelae of depression when the mother is depressed. Imagine what that would do for the state of California. And if we could do that for the nation and the world, I mean, imagine that. Incredible.
Yeah. I like that thought experiment. That would be amazing. I want to really take a moment to do some specific call outs. You've already mentioned some applications that you think are very helpful. And I'm hoping that the folks who are supporting the webinar can just drop some links in the chat to make sure these are accessible. But For people who are struggling with depression and anxiety, we've had a few call outs on the side. For teenagers, someone is working with a child sex offender. What are some of the tools that you would recommend, digital therapy tools? Would you like to start, Dr. Muñoz?
Well, at the digital apothecary, Silicon Valley Digital Apothecary that we have, Dr. Lakin has this website called Better Bet. Bet stands for behavior, emotions, and thoughts. Better behavior, emotion, and thoughts. It's basically a cognitive behavioral mood management intervention that's based on cognitive behavioral therapy, which again has been found very helpful to manage mood. And that's something that you could begin with that. Again, I strongly recommend going to Cyber Guide and to the VA apps. There are apps in the VA apps store that have been used with, particularly with veterans, but they are available at no charge to anyone. You can download them onto your smartphone. I would begin with those if you want self-help interventions. So let me stop there.
Others that you'd like to highlight?
Well, one of the benefits of working that I've found in a telemental health environment with clients is, like Donna said, even if I'm doing weekly video sessions, there's really an opportunity to do some engagement in between. And one of the things that my clients have really appreciated is if I give them a tool. So maybe we talk some about their anxiety when we meet, and we're talking about ways that they can examine their self-talk, their cognitive messages, and how do they maybe reframe those given certain triggers. And then if I follow up with a worksheet that lets them identify triggers to anxiety, corresponding thoughts, corresponding actions, and things they can replace that with, it gives them something to work through and use in between our sessions. And you can find those in a lot of places. Some of the platforms actually have some of those resources built in. I also like therapistaid.com. There's therapy worksheets there for things like mourning and depression and anxiety. And they're, in and of themselves, they're not comprehensive therapeutic tools, but sometimes they can just augment the work that we're doing with clients, and just, again, something tangible to put in their hands that clients can be working on or working through in between the time I might be meeting with them in a video session.
Can I ask you a question of the fellow panelists? So when would you recommend something like Talkspace to people in terms of depression and anxiety, and how would potential clients think about its use?
Sure. So I think if someone was there's three types of clients that I started seeing when I started with Talkspace pre-COVID. One was the incredibly busy CEO, attorneys, doctors, judges, dentists, people that had big practices. They didn't have the time. Okay, so that was a good choice for them to deal with stress management, to deal with depression, adjustment reactions, relational problems, etc. The second type of client that I was seeing was the rural client, the person who was just too far to get to a therapy appointment. And then the third type of client that I started seeing was sort of the younger, more tech savvy client, the person who heard the podcast, heard the ad for BetterHelp or Talkspace or one of these outfits, and thought, that I could do that. I have anxiety. I could do that. And they joined because they thought, well, this will be more convenient. And what they learned, especially if they'd already had a previous therapy experience, is that their outcomes and their experience was very similar to if they had a previously successful therapy experience, that they were very similar. So I would then say, if somebody's hitting upon something that they aren't managing well on their own, I think we're looking at Ricardo, you gave some great COVID anxiety stats. When we look at college students pre-COVID, college students are experiencing anxiety, sometimes debilitating anxiety, at a rate of about 60% during their college time span. Catching them before they are in a point of no return. So when they feel like life is bigger than they can handle, more than they want to control on their own, or they've hit upon a concern in their life that they'd like to talk about, but they don't really want to talk about it at home or maybe just with friends. So a lot of times that's relationship things, or maybe issues related to sex or sexuality. Another area of interest for me that has happened in seeing clients exclusively online is I've had way more trans clients in an online setting than I ever had in face-to-face, simply because it's a safer outlet a lot of times for people to be in an online setting. So those are would be the hallmarks, I think, of when I would say this would be a good choice for you. You either have a life that requires this level of flexibility, or you're tech savvy enough that this would be comfortable for you, or whatever it is that you're coming to therapy with, this may feel like a better fit for you because it feels safer and more secure.
I just have to say one thing about working with younger people, Donna, because I think that's been one of the most fascinating things. And it's something that I've learned the most as a therapist doing telemental health, is that a lot of my younger clients, especially those that opt to do more of the text chat way of therapy, they're really good at it. They're really good at expressing themselves. They're really good at letting me know what they need from me. And it's taught me so much about how to use that way of communicating with clients effectively, and to be super intentional about my choice of words, how I convey empathy, how I let them know that I hear them. And I learned so much about how to do that from them. So that to me has been one of the most fun ways. When I told my 20-year-old son that I was going to start doing some text chat therapy, and I was like, I don't know how this is going to go. He's like, are you kidding me? If I had to go to counseling, that's probably the only way I would do it. And I was like, oh, okay.
And I get pictures from clients.
Oh yeah, and memes. They send great memes.
Great
It's
memes.
awesome.
Great memes. I get pictures of this is what I'm doing today. Remember I told you I was going to do some self-care? Here I am doing it. I get links to their art. Maybe they have an Instagram with their art, or they've been producing a video. It really lets me into a side of their life that I wouldn't get in a sitting down in my stuffy office kind of thing. It has been revolutionary in my experience. And I really joined the digital world as a skeptic. 25 years as a practicing counselor in a more traditional style, I thought, okay, I'm going to give this a try, but I'm not really going to put all my eggs in this basket, and have completely converted to seeing the value.
I wanted
we were going to be doing a study at Palo Alto University based on a study that one of our colleagues from Sweden who's been visiting did with adolescents who were severely depressed. These were kids who had clinically really major levels of depression, and it was a blended therapy model where they did some following a traditional cognitive behavior therapy and then had a real live chat with the therapist once a week. And what was interesting was that Dr. Topoco looked at what the clients, these kids, the adolescents felt about the chat, and they loved it. And the interesting thing is they love their therapists. So one of the issues for all of us who do therapy is how you connect. So here's an example with adolescents where not actually seeing the patient didn't really seem to impede a connection between those two people. One of the things, Laura, just a little bit response about accessibility is, as in this revolution continues, there are things we need to do in this country. I'm not directly answering your question. If you compare what's available in Sweden, for example, or in the Netherlands, or in Australia, in England, we wouldn't even need to have this conversation because people could get all of the things we're talking about readily available and basically for free. So I think as a public health person interested in the whole population health for mental health, we need to do a better job in America in a number of ways. We need to, at a training level, make sure that all of the kind of training in digital therapy is supported by the organizations. That PAU is just so far out there in terms of being an incredible organization for training. The limits are the professional organizations. Secondly, practicing across state lines has to change. For instance, psychologists and practitioners should, many of us think, have a national license so that, I mean, it's kind of ridiculous, right? I have a patient who I'm seeing with teletherapy that's in San Francisco, and she decides to go to Nevada, and I can't see her anymore because of practice guidelines. I'm the same person, the same therapist, same person. We've been working together for a long time. She's doing great. So there has to be a bit of a change in the regulation and in reimbursement in all of the directions we're talking about, because as that happens, it will open up many wonderful opportunities in this country. So we're doing great. We've made a lot of progress, but we have a long way to go.
I'd like to ask a follow-up, or just a quick follow-up to Dr. Taylor, and then Dr. Muñoz, let's hear from you. That is a question that we've got from one of our listeners, is there any movement by the APA or ACA to open up teletherapy between states, or even to address some of these larger issues around, the changes that we've seen in COVID regarding insurance? If you could look into your crystal ball and tell us, do you think some of these things will stick in the future, or we'll see shifts away from some of these long-term challenges we've dealt with?
Absolutely. Finally, the APA is getting enlightened about the need of this. We had put together a digital training available through PAU and the American Psychological Association. Someone named Greg Niemeyer had asked us to do this. It was great, and people really liked the training and so forth. And so I wrote him to say, you were like a visionary, you really opened this up to the future of mental health. And he wrote me back and said, well, we have 45,000 programs we've sent out in the digital space. And even perhaps equally important, the APA is convening committees to address the two issues that you have met, licensure and reimbursement, and really to try to move the field forward. So the answer is hopefully, absolutely yes. If the training changes, the regulations and the practice and the reimbursement, we'll live in a world where people are afforded incredible opportunities that we don't have to dream of anymore, because we've actually done many of them,
And this is where COVID has actually helped the process of digital therapy, because we've had to make these changes. States have had to be a little more flexible. Licensure boards and regulatory boards have had to get creative about what is allowed. And once the horse is out of the barn, it's hard to put it back in. So this is something Barr and I talk about a lot. We are really hopeful that if we just keep proceeding forward, that we will be able to see patients in California and beyond, because we will have established a way to do so that is well directed, it is empirically based, and it fits now with a national model.
Dr. Muñoz, you wanted to add something.
Yeah, two things. First, some resources that we have available that anybody can download from our site at PAU. And you can Google Silicon Valley Digital Apothecary and then click on the resources tab, and you'll find about a dozen manuals for the treatment and prevention of depression that are in English, in Spanish. There are manuals for therapists, and there are manuals for the patients. And you're welcome to see them and see if any of the ideas there are useful to you. We have them available in addition to Spanish and English. We have some available in Japanese, Korean, Chinese, Greek. There may be some other languages there. But anyway, anybody can download them. We don't charge for them. You're welcome to use them. We also have there, we have an online training module for the use of our latest depression treatment manual, which goes step by step. It goes session by session as to how a therapist would provide this. So if there are any therapists in the audience and you want to use our manuals, again, we do not charge for that online training. And then in the Silicon Valley Digital Apothecary page, there are links to two webinars that I did for how to prevent depression during COVID, one in English and one in Spanish. That was the first thing. The second thing, I wanted to talk about the public health issue that Dr. Taylor mentioned. one of the things I've learned over the years is the difference between consumable and non-consumable interventions. Consumable interventions are interventions that are used up when you administer them. For example, the nicotine patch. What do you do with the patch at the end of the day? You throw it away. Right? The same thing is true actually for cognitive behavioral therapy. When I do a cognitive behavioral therapy session, at the end of that hour of my time is used up. It's gone forever. No other patient will ever be able to benefit from that hour of my time. That's why healthcare is so expensive. And it doesn't matter if you charge or not. I founded and run a depression clinic at San Francisco General for 10 years. We did not charge patients anything for that. We used it as a training clinic. And so it's not the money, it's the time, the professional time involved. But non-consumable interventions like websites and apps can be used again and again and again and again without losing their therapeutic power. They don't drift away from the way they were tested. It's just amazing. If a site costs you $1 million to create and test, 1,000 people use the site, each one would cost $1,000 to administer. But if 1 million use it, each one costs $1. And if 10 million use it, each one costs 10 cents. That's amazing how it drops down. So we really need, if we really want to do public health and reach as many people as possible, we need to develop more of these fully automated sites, test them to make sure they work, of course, and then make them available to anybody. Anybody in California, anybody in the country, and why stop at the border? Anybody in the world.
Great. Thank you. So I want to turn now to some of the questions that we've received from the audience. And so let's start with overall, what are your thoughts about online group therapy? We haven't talked about that much. Whoever would like to take this.
I love it, actually. I haven't done it for quite a while, but years ago at Stanford, Dr. Spiegel had a group therapy for women who were dealing with breast cancer, and we developed a synchronous group, which was basically an asynchronous group. So every week the participants would talk about it. We had spectacular outcomes with this group, and we had a very, very experienced group therapist that was moderating the group, and she said her experience in the group was actually better than it had been in face-to-face, because the women were so open and disclosing, in addition to creating incredible levels of support to one another. I think it's one of the big holes in digital therapy, and others probably know more about what's current than I do, but I think it's potentially really a wonderful resource. And there are lots of groups that, in my world of eating disorders, I was just on, like with anorexia nervosa, ANAD, and NIDA have. If you go there, you can find long lists of groups that can provide support. They tend to be actual, kind of people chatting groups. So yeah, I think they're potentially fantastic.
A lot of the groups are being run much like this webinar looks. So you might have 7 people joining a Zoom room for a synchronous group with a therapist. What that does is cut down on barriers for attendance for a lot of people who would want to be part of a group, but again, that whole driving across town, or they could slip away to a private room in their home to be part of a group when they couldn't attend a group in person. Childcare issues with women come up a lot when we're talking about in-person groups. So again, there's a lot of advantages to it. What we don't really have is a robust set of literature around group interventions yet, nor do we have a lot of literature around the supervision of people in training to do this type of work. So we've just started doing some of these groups. I wouldn't say just start. We've done some in our group classes to train our students, so they've had that experience at PAU. But it is a different mindset to facilitate a group in this type of virtual space than it is to facilitate in a circle in a room, as you might imagine. It just takes a different skill set.
Groups can be very powerful, by the way. We run depression groups. We rotated patients. So patients would come in at the beginning of a module focusing on thoughts, another one on behavior, another one on people. And so each one had 4 sessions. So each month we would bring in more patients, and some would rotate out. And what would happen is some of the patients who had been there for a few weeks would tell the ones who had just come in, who were maybe crying a lot during the session, you know, I cried at least as much as you did when I first arrived, and look at me now, you know. And a patient who has just arrived at a group feeling very depressed, and again, you know, very distraught, crying a lot and so on, doesn't believe the therapist when the therapist says, you know, you're going to feel better. But when another patient says, you know, I was crying at least as much as you, and I'm doing so much better now, they believe the other patient much more. So groups are very powerful.
Another thing I think COVID has kind of forced the hand of is how we look at even things like support and recovery groups. So Alcoholics Anonymous, Narcotics Anonymous, Al-Anon meetings, those communities that offer those meetings have had to find ways to pivot to virtual opportunities for clients. And I know I've had a few cases with some of my own clients where I have, during a session, a video session, I've shared my screen and we've gone online together and we've done a search for a local AA meeting that has moved to a virtual platform that they can access. So I think, again, we didn't see as many of those opportunities pre-COVID, but now I think there really is a responsiveness to all of the ways in which people seek help, whether it's therapeutically, whether it's through a support group or a self-help type of group. And so it's really encouraging to me to see that we are kind of rising to that occasion and offering those kinds of opportunities.
We have just about 8 minutes left. So I really want folks to plug in their questions if they have them and have not yet done so. We're doing our best to try to answer most of those. You can do it in the Q&A just below. If you look down below the videos, there's a little Q&A box. So go ahead and type those in. We just had one come in that said, BetterHelp pays licensed therapists only $25 per 50-minute telehealth hour, a video or audio session. It could indicate the Uberification of the profession. What are your thoughts on that?
So I actually just responded to that. Maybe I didn't respond in the correct place, but if I'm not mistaken, that cost is actually, that charge is actually on top of what the subscription-based charge is, and the therapist is also receiving a portion of the subscription in addition to the portion of each live hour, if you will. What I have done in my practice, and it is not my bread and butter, so I can utilize a practice like Talkspace or BetterHelp or a platform for a small private practice. I don't have any overhead. I don't have to do any recruiting. I don't have to bill insurance, which is a colossal headache, as providers know. Is I actually calculate my hours per week and the amount of time that I spend versus my ultimate monthly payout, if you will. And that comes out to around $60 an hour for me, which is not great if I'm in the Bay Area and could charge $250 for that hour. But for the type of work that I do, given that I am a clinician and an educator, it works for me as a therapist. Does it reduce the what the therapeutic hour is worth? I think that's a great philosophical discussion, but I see the need for both. As I think Barr mentioned earlier, we simply don't have enough providers. So we don't have any difficulty filling the full price therapists in the Bay Area. You can't get in, and we don't have any difficulty filling our sliding scale folks either.
I'm hoping you can all talk about accessibility. You've sort of pulled out little pieces of it and how it's been easier to work with populations that have traditionally not used the in-person therapy as much, or it hasn't been available to them as much. What does this move towards digital therapy mean for accessibility?
I have so much to say about this, but I was just talking, so Oh my gosh, our rural people who don't communicate well verbally, but communicate well in typing, people who might have cerebral palsy or another differing ability that makes it difficult to attend an in-person session in that way, people who don't have transportation, people who ordinarily wouldn't seek services because of stigma, just so many opportunities. I get really excited about what a social justice initiative digital offerings are. I'll be quiet.
I used to run a mental health center in southern Utah and a bunch of rural communities, and there were no services for any of these folks. So from the standpoint of accessibility for underserved rural areas, it's huge. Ricardo would mention some other areas I think are incredibly important. People who have different languages that can benefit by a therapist. They may not have someone in their own area trained in Spanish or Chinese or Urdu or whatever. So, and then I think that disability is not a trivial issue about accessibility that I feel quite strongly about. There are a lot of people who are in nursing homes and shut in other places that really don't have the physical ability really to have any sort of access to services. So this I think is one of the reasons many of us do what we do, thinking that eventually as we deal with the big issues of licensingship and protection of HIPAA and so forth, and practice across state lines, et cetera, that it will allow us to provide services to a lot of people who can't get them otherwise. How about undocumented immigrants? Are they going to be willing to come to a clinic because of all of the issues, the legal, the stigma, and otherwise? I don't think so. So it will be, I think, part of the real potential to provide a kind of a more just mental health system to people. And then just in terms of the difficulty of getting anywhere around places, it really opens up that accessibility in a way which is really wonderful.
I saw a request for screening. Is there any screening instrument? And there is a screening instrument at Silicon Valley Digital Apothecary, at that website that Dr. Jan Laken has. It's called a mood screener. And it checks for major depressive episodes. And it gives individualized feedback depending on what your responses are. It checks for whether you've had an episode in the past and whether you have a current episode, and it suggests what you ought to do depending on the number of symptoms that you are experiencing. It's in Spanish, English, Chinese, Russian, and Arabic.
Wow, that's great.
And it's for free. It's free. It's no charge. So.
Wonderful. All right. Well, thank you all so much. And thanks everyone for joining us. This is part of a series that Palo Alto University has been doing, focusing on mental health during the pandemic, which I think is an incredible service to us all. So thank you all for doing that. The next webinar that they are having is called At the Forefront of Mental Health, or excuse me, it's the next in their series. The series is called At the Forefront of Mental Health, and it takes place on Tuesday, November 17th. It will focus on the impact of disasters, disease, and disruption on mental health. So hopefully you will join the folks at Palo Alto University for that. Thank you all so much. And thanks to our wonderful doctors for all your insight and for the great questions that we've gotten from the audience today.
Thank you, Laura.
Thank you.
Thank you, Laura, so much.